A lot of things go on in the head. Children, they need to be exposed to bugs to develop an immune system. Now that means that orifices, that is the nose, the mouth, and the ears, they can become potential sites for problems to develop. And that is why this topic is discussed in pediatrics. Now, each of these diseases has its own unique presentation, so it's usually not a differential. You just know what to do. So, welcome to this channel. My name is Dr. Sayed Kazmi, and today we will be talking about the pediatric ENT disorders, and I will be focusing on high yield practice points. But if you haven't subscribed to my channel yet, please do subscribe and give me a thumbs up, and also press the bell notification icon so whenever I upload a new video, you are always on board with me. So let's dive and get started. So the first thing that we are going to discuss today is otitis media. Otitis media means infection of the middle ear cavity, and it's caused by respiratory bugs. In practice, it is seen that most of the cases are viral in origin, but nevertheless, bacteria can also cause acute otitis media. Now, the child who's got otitis media is going to be in pain, and usually it's unilateral. So this child would be having a unilateral ear pain with or without fever. Now, kids will usually pull on their ears, but remember, in case of otitis media, there is usually no pain with pinna manipulation to relieve the sensation. The diagnosis is usually confirmed by pneumatic insufflation, in which a little puff of air reveals a tense, immobile tympanic membrane. Now, when you do otoscopy and you see things like bulging red angry membrane with loss of light reflex, it is indicated of fluid behind the ear, but it is not pathognomonic of otitis media. So keep it in mind that though if we see a red bulging membrane and with the loss of light reflex, it is indicative. It is not diagnostic, because the only one thing that is diagnostic of otitis media is pneumatic insufflation, which we rarely do. Okay. Now, these types of infections, they are treated with amoxicillin, which is a first-line drug, because the pathogens, bacterial pathogens that usually causes, the most common is Streptococcus pneumoniae. It is followed by non-typable Haemophilus influenzae. I'm not talking about the Haemophilus influenzae type B, but the non-typable strains of Haemophilus. And the third one, important bacterial strain, is Moraxella catarrhalis. Now, most of these bugs are quite sensitive to amoxicillin, so that's why amoxicillin is the first-line treatment of otitis media. If the infection doesn't clear with amoxicillin, then we have to give co-amoxiclav. Please also keep it in mind that if kids who are allergic to penicillin, you can give them either clarithromycin or azithromycin. So amoxicillin or clarithromycin or azithro is the first-line drug for acute otitis media. That should clear up the infection in most of the cases. If it doesn't clear it up, what is the next step? Co-amoxiclav. If it occurs again and again, then obviously something else needs to be done, and in that case, because usually if they've got recurrent otitis media, that would lead to what we call as a glue ear, so there will be fluid behind the ear. This actually means that they actually go on to chronic otitis media. So in that case, we need to equalize the pressure on both sides of the membrane. So we have to put grommets in the ears. That would allow the pressure to equalize on both sides, and also allows the fluid behind the middle ear to drain outside, and that would prevent deafness in the long run. So remember these things about otitis media. Now, moving on, let's talk about otitis externa. Now, otitis externa presents as unilateral ear pain, just like otitis media. So remember, the presentation could be the same. Otitis media and otitis externa both present with acute, in most cases, unilateral ear pain. Remember, sometimes kids who have got problems can also present with bilateral otitis media. That's a bit rare. So otitis externa, otitis media, especially if they are unilateral, can present like with the same symptomatology. But in case of otitis externa, there is pain on palpation of pinna, unlike media. So pain could be like the dull pain could be in both of the conditions. The only thing is that if the child pinna is manipulated, that would lead to excruciating pain in case of otitis externa, but not in case of otitis media. So this is one clinical differentiating point between the two. Also, as far as organisms is concerned, most of the time it is caused by Pseudomonas, and Pseudomonas is a bug which is associated with water. So it is caused by frequent contact with water, like those kids who are swimming a lot, they might develop otitis externa. Sometimes it is also occurs with kids who've got eczema of the ear canals. It can also be caused by repeated trauma and infection by Staphylococcus aureus. So if you put an otoscope inside and you do the examination, you might see an angry erythematous ear canal. Though most of the cases they do improve spontaneously, but sometimes you can treat with ciprofloxacin drops. So 0.3% ciprofloxacin ear drops are a good treatment for otitis externa. It also becomes very important to educate these kids or their parents not to put anything in their ear and to dry their ears after swimming and showering. So this is very important practice point for otitis externa. Moving on and talking about sinusitis. Now, sinusitis occurs in older children. It's quite rare in young kids. Number one, kids are born, they do have like a maxillary sinus when they are born, but these sinuses take time to develop. Frontal sinuses usually they don't develop before a child is 9 or 10 years of age. The sinusitis is very rare in kids who are less than like 9-10 years of age, unless until they've got like some anatomical defects in their sinuses. So it would be usually the teenagers or adolescents who might present with sinusitis. The sinusitis, in very simple words, is infection of the nose sinuses, all those sinuses which are surrounding the nose. So it could be the maxillary sinuses, it could be ethmoid sinus, it could be the sphenoid sinus, it could be the frontal sinuses. Most of the time, it is the maxillary or the frontal sinuses which are infected. Usually these kids have got some existing problems, either they might have attenuated septum or they might have some anatomical defects in their facial bones which like predisposes them to develop sinusitis. So how do they present? Usually most of the cases they present with purulent, we call it like greenish, dirty, greenish, yellowish, foul smelling bilateral nasal discharge. So it's not unilateral, it's usually bilateral. Unilateral discharge, you have to rule out foreign body. Bilateral is in older kids is usually because of sinusitis. And whenever a child or a adolescent has got a purulent bilateral nasal discharge, it means that there is something wrong nearby in the sinuses. They also may complain of a congested, stuck feeling in the nose, and they might have some sinus tenderness. So, like if you do facial tapping, they might have like tenderness on the forehead, or they might have tenderness to facial tap on the maxillary sinuses, and that's why facial tap is a sensitive physical finding because tapping an inflamed sinus always hurts. Now, in the past, radiographs used to be done because they would show air fluid levels and opacification, especially if there was chronic sinusitis in the sinuses. But these days, X-rays are not done. In chronic sinusitis, usually CT is done, but it's in most of the cases it's a clinical diagnosis. You don't need to go very often for a CT scan to rule in sinusitis, because they are expensive and they are usually reserved for refractory or what would we call it as recurrent sinusitis, and to make sure that there's no congenital defect in the sinuses. But before you label somebody with having a sinusitis, it is important that you make sure that it is not just a cold, which is just a regular viral illness. So if it has been only greater than 10 days or is getting worse over a week, so somebody who's got like a stuffed feeling in the nose with bilateral purulent nasal discharge, plus minus, sometimes there could be fever, sometimes there might not be fever, especially if they're taking like antipyretics. So you think of sinusitis. The only thing is that it very closely resembles like upper respiratory tract infections as rhinitis. So you have to wait for a week to 10 days. So only if it is greater than 10 days that you would be presuming that it is a bacterial infection. And usually, because it's an upper respiratory infection, if it is bacterial one, we would treat them with amoxicillin, which is the first line, or if they are allergic, we would treat them with azithromycin or clarithromycin. Moving on and talking about one of the most common illnesses of children. This is by and large the most common illness of all times. Kids, adults, old age, anyone. We call it common cold. Now, common cold can be caused by a variety of different viruses. I think there are more than 200 different types of viruses which can cause common cold. But by and large, the most common are rhinoviruses. So the rhinoviruses is a family of viruses. And again, there are so many within that that can cause common cold. So infection by one does not confer immunity, lifelong immunity. You can get infection from another member of the same family. So rhinovirus is by and large the biggest family that causes common cold. After that, we've got the coronaviruses. And I'm not talking about the COVID-19 here. There are other coronaviruses as well, alpha as beta, which can cause common cold in children. So these are trivial bugs and they just cause a viral illness for 4 or 5 days and then it goes away. Apart from then, the one which can cause a bit like little bit more severe variety of common cold are adenoviruses. So adenoviruses again they cause like what we call as rhinopharyngitis, but usually it's a bit more severe because there might be a bit of more high grade fever with that, and or there can be like bilateral conjunctivitis with adenoviruses as well. So most cases of common cold, and again remember the presentation can be very varied, but in most cases it usually presents with mild fever. So either the fever would be there or the fever might not be there. But if the fever is there, in most cases it's just a mild fever with rhinorrhea. So usually in the beginning, as the virus is multiplying in the nasal passages, like it activates the cyclic AMP and GMP pathways, and there is a lot of like secretions coming from the nose. So there is clear rhinorrhea. After some time, it might become a bit more thick, and then that would lead to congestion, as thick secretions are not easy to get rid of. So that would lead to stuffiness. So beginning mild fever, then rhinorrhea, followed by congestion. And because the same secretions are, dripping back into the throat as well, that leads to irritation of the larynx and cause a dry hacking cough. So a tickly sensation in the throat is because of these secretions dripping down, and it can lead to a troublesome dry cough. If it goes further down, then obviously it can lead to more complications, but usually in most of the cases they are mild, so it can lead to bronchitis, might lead to bronchiolitis in very young kids, or it might lead to acute viral wheeze in those kids who are susceptible. So it either might remain as a mild upper respiratory tract infection, or sometime it can go down, cause bronchiolitis in very small infants, or might cause acute viral wheeze as well. Findings are usually limited to if you examine their throat, they've got like mild pharyngeal inflammation. So just a non-specific mild erythematous pharynx, or a bit of inflammation on the tonsillar pillars, along with clear or mucoid nasal discharge. You might see like a sort of a clear or a thickened, like sometimes it can have a little bit of yellowish tinge to that as well. And as I told you that in very young kids, it can lead to bronchiolitis, and a little bit older kids can have acute viral wheeze. So usually it will start with that, but after 4 or 5 days might go down. As I told you, can present with these complications as well. No treatment is necessary for common cold. Most of the cases they get better on their own. So within 5 to 7 days, sometime it can go up to 10 days, depending on which virus is causing that. Again, I told you more than 200 different types of viruses cause that. Like if it is adenovirus, it will give you a bit more higher grade fever, and it will take a bit more to calm down as compared to the milder viruses belonging to the rhinovirus or the coronavirus family. So no treatment is necessary. All that is needed is if the child is uncomfortable or is got fever, paracetamol is what is needed. If the fever is not controlled alone by paracetamol, again, then it can be alternative with ibuprofen. Clears what you call nasal discharge can be cleared often, or if there is congestion, then saline nasal drops can be put in the nasal cavity every 4 hours to loosen this thickened secretions and make it easy for the child to either cough it out, sneeze it out, or simply like swallow that and get destroyed in the stomach. So no treatment is necessary. Most of the cases would get better within 7 to 10 days on average, but you should always tell the parent that the cough would be the last thing. So if a child has got a dry, tickly cough with the common cold, that's usually the last thing to go. So it will take a couple of weeks usually, so 2 to 3 weeks. The dry cough stays on, and then slowly and gradually gets away, because the viral remnants, they remain permanently attached to the to the cells, the epithelial cells, and it's causing a constant activation of the CAMP and CGMP pathways, leading to secretions, postnasal dripping, and that leads to a constant dry cough, which is more troublesome at night. So again, different types of symptomatic treatment can be given, but we don't recommend antihistamines in very young kids because the potential for side effects is more as compared to any beneficial effect that might be given by these antihistamines. So that's why it is not recommended. They don't make any much difference as far as the improvement in cough is concerned. So bottom line is no treatment is required for common cold. Then moving on to two other conditions, pharyngitis and tonsillitis, one of the most common causes of fever and presentations to the emergency departments. Now, what is pharyngitis? Pharyngitis, in very simply word, means inflammation of the posterior pharyngeal wall. So the posterior pharynx, if you see the picture on the right side over here, this one, let me draw. So if you see over here, so there is a mild diffuse inflammation of the posterior pharyngeal. So this is the posterior pharyngeal wall. Here you can see the posterior and the anterior tonsillar pillars, and this is the uvula. So you can see like dilated blood vessels, capillaries over there with a bit of redness, mild redness. So this is what we call as mild grade inflammation of the posterior pharyngeal wall and the tonsillar fosses, and this is characteristic of viral pharyngitis. So pharyngitis in most cases is viral in nature. Rarely, if it is associated with inflammation of the tonsils, sometimes it can be caused by bacteria, and but still, like statistics show that most of the cases are still viral in nature. So it usually presents as a sore throat. So the most important finding is a sore throat. So child would complain that his throat hurts, and when the throat hurts, they usually have got pain on swallowing. So they're not able to swallow without pain. So that's why younger kids who usually refuse to eat. So one parent would bring their child with fever and let's say a little bit of runny nose, and they would say the child is not eating, he's refusing to eat. Why is he refusing to eat? Because there is inflammation, it is a painful condition. So when the child tries to eat or swallow something, it hurts. So that's why they refuse. You give them something and they will push it out and they won't take it. And there could be plus minus fever. Some of the cases might have got a mild fever, some might not have a fever. Again, it depends on which virus is causing them. Sometimes the fever can even be of a moderate grade, where it can go up to 38.5 and sometimes even 39. It can sometimes lead to tonsillitis or might coexist with it. So if it coexists with tonsillitis, we call it pharyngeal tonsillitis. Again, most of the cases are viral in nature. Sometimes if it is associated with lack of cough and a bit of adenopathy, then you can think of bacterial infection, and streptococci are the common bacteria that can cause bacterial pharyngitis. So for that, we can do the rapid streptococcal test. So it's an antigen-based test. It's a quick one. It's very specific, but it's not sensitive. So it simply means if it is positive, you can like say, oh, well, fine, this is being caused by, let's say, group A streptococci. But if it is negative, it does not rule out. So if somebody is fulfilling the central criteria, which is actually the criteria which we use to see if a child would need antibiotics or not. So we use a center criteria. So the thing is that if rapid strep test is positive, well and good. If not, then probably we will have to go for taking culture swabs for cultures and see which bacteria is known. So central criteria is a criteria which gives you, excuse me, 4 or 5 marks for some of the features that we look for. So 1 mark for fever, 1 mark for if there are exudates on the tonsils, 1 mark for adenopathy, 1 mark for if there is no cough, and obviously 1 mark if the child is less than 15 years of age, and we minus 1 mark if somebody is more than 44 years of age. But obviously I'm just focusing on pediatrics. I don't want to go into that detail. So somebody who's got 1 score, well, that you would treat as a viral one. Somebody who's got 2 or 3 score on the central criteria, you probably would think there might be a chance that it might be bacterial. So the best thing would be to do a quick rapid streptococcal antigen test if that is available. If it is 4, then obviously you have to treat them with antibiotics. So usually the antibiotics that is used are penicillin. So phenoxymethylpenicillin is used here in UK. It's a narrow spectrum antibiotic, but it's very good for the common bug that causes pharyngeal tonsillitis, and that is streptococci. So group A streptococci are still very sensitive to phenoxymethylpenicillin, which is otherwise a narrow spectrum antibiotic. So it is only used for tonsillitis. So you would use that. If you think it is viral, the best would be to give them benzidamine 0.15% throat spray. So this is an anti-inflammatory throat spray, and it just cools down the throat. It reduces the pain sensation on the throat, so the child can swallow, the child can take his food, take his feeds, whatever. So benzidamine 0.15% spray can be used every 4 hours. And as I told you, if it is bacterial, you would either give them phenoxymethylpenicillin, or if they're allergic to it, then you would go for the macrolides, erythromycin or clarithromycin, whatever you've got available with you. A tonsillitis means inflammation or infection of the tonsils. Again, it can be viral, it can be bacterial. Again, we use the central criteria to differentiate between viral and bacterial. Most people I've seen in practice, they're still treated with antibiotics, though the stats like the microbiological statistics show otherwise. Still, like those which feel like bacterial are still viral in origin. So it's mostly viral, but usually if there are heavy exudates and pus on the tonsil, like for example, if you see this picture on the right side, you can see that these are the two inflamed tonsils, and you can see islands of pus. So there are whitish, these exudates on the tonsils, and both tonsils are equally enlarged and inflamed. So this is bilateral tonsillitis. Again, tonsillitis in most cases are bilateral. If it is unilateral, then you would be thinking of like quinsy. Uh, what we call as like paratonsillar abscess. So mostly viral, but if there are exudates, you would think of bacterial infection. As I said, rarely it can lead to a secondary development of pus behind the tonsil. We call it as quinsy. In quinsy, you will see that one tonsil is bigger than the other one, and usually the uvula is deviated to the opposite side. So if that is the case, then antibiotic alone would not help. That abscess needs to be drained, and obviously you would involve the ENT guys at this point in time, because the area needs to be numbed, and obviously after numbing they will put a needle in and drain the abscess. Again, this bacterial tonsillitis is treated with phenoxymethylpenicillin. It's a narrow spectrum antibiotic that, as told you, very effective against streptococci. If a child has got more than 4 attacks per year, which requires antibiotics or is affecting the quality of life, now that child becomes a candidate to have elective tonsillectomy. Again, different trusts and different school of thoughts have got different guidelines, but nevertheless, I mean, if somebody's life is being affected, if they've got like not many attacks of tonsillitis, then they should be considered for tonsillectomy. So if they're not improving after 5 days of antibiotics, then you should be considering other conditions that can mimic tonsillitis, especially the Epstein-Barr virus infection. So if a child is adolescent or a teenager, develops tonsillitis, you see and you diagnose it as tonsillitis, you give them antibiotics, amoxicillin or phenoxymethylpenicillin, they're not improving with it. Rather, sometimes they might deteriorate, they might develop a rash, or simply the symptoms are not improving, then you should be thinking of Epstein-Barr virus infection. And in that case, it's very important that rather changing antibiotics, you should be doing a monospot test to rule out Epstein-Barr virus infection. Or rarely, it could be a sign of leukemia as well. Remember, leukemic infiltrates in tonsils can cause tonsillitis, and that tonsillitis doesn't improve because it's suppressed immunity, and antibiotics alone cannot do that. So remember, a tonsillitis practice point, a tonsillitis which is not improving. If it is an adolescent, think of Epstein-Barr virus infection. Irrespective of the age, if it is not improving, you should also consider leukemia as well. So obviously you would do the blood test, and you might have to do a chest x-ray to rule out hilar adenopathy as well. Moving on and discussing the final topic in pediatric ENT disorders, and that is epistaxis. Again, that is one of the common causes of visits to ED. And epistaxis means bleeding from the nose. So bleeding from the nostrils is epistaxis. It could be anterior epistaxis if it comes out through the anterior nostrils. It could be posterior epistaxis if it is trickling back into the oropharynx, and then might lead to hematemesis as well. But nevertheless, some of the cause is in the posterior pharynx. Most of the times it is caused by a habit which is we call as nose picking. So kids have got like habit of putting the fingers in their nose, picking their nose, removing the boogers, and by that process they can damage the delicate blood vessels, capillaries, and the nasal epithelium, leading to epistaxis. And in most of the cases it's unilateral, and again in most of the cases that bleeding episode lasts less than 30 seconds. So kids can get this off and on. If it is bilateral, obviously you have to rule out other causes, because sometimes trauma to the facial area, especially the bridge of the nose, leading to nasal fractures and other things, can cause bleeding. Rarely, some clotting disorders, especially von Willebrand factor deficiency, can also present with recurrent epistaxis in children, or some of the qualitative platelet defects like Burnout Solier or Glass thromboasthenia can sometimes again present with present with epistaxis. And rarely, it might be also a feature of what we call as hereditary hemorrhagic telangiectasia, which is also known as Osler-Weber-Rendu syndrome, in which you might see that there are small telangiectasias on the skin. So these are malformations of the capillaries, and it is present in the nose as well, and it can bleed with little bit of pressure, trauma, or even when the ambience is hot. And in adolescence, it could be the secondary to growth inside the nasal cavity, most commonly nasopharyngeal angiofibroma. It's angiofibroma because it's made of fibrous tissue and a lot of blood vessels which can bleed on touch. So that can cause it. Remember, most of the time it is usually caused by finger picking or digital trauma. But if it is occurring, if it is recurrent, or if it is associated with other symptomatology, then you have to do a workout. So you look at the QEG profile, you will look at the platelet count, you might do the von Willebrand assays to see if there is any von Willebrand deficiency, and you might have to do a CT of the sinuses, or you might have to put a scope inside to see if there is any growth inside the nasopharynx. The other thing is also, always whenever you are dealing with a case of epistaxis, always examine the nose to see if there is any foreign body. Kids sometimes they put foreign bodies inside their nose, and that can also damage the nasal epithelium and lead to epistaxis. So how do we treat it? Treatment is by compression of the nares. So we always ask or the parents to pinch the nose, and obviously they have to bend forward. They do not have to bend backward, because if they are bending backward, pinching of the nose, if they would just be drinking their own like epistaxis, so posterior epistaxis, and the blood would be going down and into the stomach, and later on they would have like vomiting, which would have blood. So the best thing is to pinch the nose and lean forward. If it is posterior epistaxis, then obviously you have to put a tampon inside. It's just like you have to do a packing. And obviously, when you're doing the packing of the nasal cavity, you have to give them broad spectrum antibiotics to cover staphylococci as well, because staphylococci can cause widespread, infection when you're using these packings and other things. So the bacteria staphylococci can simply that can be pushed inside in the blood and cause havoc within the body. So if we treat it with pressure, yes, if it is repeated one, and if you haven't find out any other cause, you have ruled out von Willebrand deficiency. If there's von Willebrand deficiency, we treat it with desmopressin. But nevertheless, I mean, if you have ruled out these causes, like other causes, if somebody has got recurrence, then cauterization can also help. So chemical electric cauterization of the bleeders can help, or in cases of chronic, sometimes humidified air also helps in improving the epistaxis and reducing the recurrences. So this was all about some of the common high yield pediatric ENT disorders which you normally see in practice. These are the cases which you would normally see in your emergency department. This is your day-to-day practice. So we have discussed some of these common conditions, how to differentiate between them, and what is the treatment. So once again, quickly revising that, otitis media is infection of the middle ear cavity, usually unilateral, but sometimes can be bilateral as well. And there would be fever with pain, but remember, when you are manipulating the pinna, there is no pain, because the pain is because of the middle pressure in the middle ear cavity, not on the outer ear canal, which would cause pain by pulling on. In otitis externa, when you are manipulating it, it's excruciatingly painful. So if a child cries, like even if you pull out, that is otitis media. If he's tugging onto the ears, he's got fever and everything, but he is otherwise comfortable, I mean, then it's probably otitis media. But nevertheless, you have to do otoscopy to rule out between these two things. Then as far as sinusitis, it's more common in older children. We talked about pharyngitis and tonsillitis, which are mostly viral, but can be bacterial as well, and they are treated with amoxicillin or phenoxyethyl penicillins. And then we talked about epistaxis and told you that epistaxis is usually caused by digital trauma. It is treated by pressure and forward bending. If it is recurrent, then you can think about cauterization or treating the underlying condition if you find out any. Okay, so this was all about these conditions. Hope you have liked this video and I hope you have learned something. So if you have learned something, do apply it in your practice. And if there is still any question or if you are puzzled about something, you can put your question down in the comment section below, and I will try my level best to answer you as soon as possible. So thank you very much and have a good day. Bye bye.